the oh, okay, start over. Hi everyone. I'm Megan Martz, and I'm the co-leader and facilitator of the Lunch and Learns along with Alex Weigard. And today we are excited to have Dr. Deb Crawford with us, and she will be talking about affirming care for LGBTQ plus individuals with co-occurring disorders, practical and therapeutic considerations. Dr. Crawford received her PhD from the University of Missouri St. Louis in counselor education and supervision. She is an assistant professor of counseling at Eastern Michigan University and has previously taught in the mental health counseling program at the University of Central Arkansas, as well as at the University of Missouri St. Louis. She is a licensed professional counselor in Michigan and Missouri and has worked in private practice for over 8 years counseling adolescent and adult clients. Dr. Crawford's research focus is on factors related to resilience and thriving in the LGBTQ plus community and counseling skill development. She has several published works, including academic research articles, textbook chapters, and magazine articles on mental health in the LGBTQ plus community. So we're excited to have her here. And I will note, because this is a webinar, that it would be helpful if you could put your questions in the chat because you won't be able to directly ask the questions. So put them in the chat and you can put them in whenever you want, but I will read through them at the end of Dr. Crawford's talk today. All right,
Awesome.
go ahead.
Thanks, Megan. Hello, everybody. Well, I guess I can't really see you, but glad you're here. So let's talk a little bit about what we're going to talk about today. So we don't have a ton of time, so if it does feel like a lot of information in a short period of time, I apologize. But just try to give you as much as I can, in the short, 45 to an hour minute time that we've got. Subjectives for today, understand the role that holding an LGBTQ plus identity may have on the prevalence, etiology, and treatment of co-occurring disorders. Identify relevant statistics around the prevalence of co-occurring disorders, I'll probably call them CODs just for short, in the LGBTQ plus community, and apply relevant multicultural and ethical treatment strategies for working with the LGBTQ individuals with co-occurring disorders. I did try to keep this general. Obviously, my background is in counseling, but I did try to focus on things that could apply, no matter, kind of what discipline you might be in, whether you are a medical professional or a social worker or a counselor or psychologist or whatever. So one thing I do want to start out with are some definitions. I don't want to assume that folks know what these are. So I do want to just talk about two terms and kind of the identities that fall kind of within those. So when we look at folks in the LGBTQ community, when we look at like the research base, in kind of splits within like sexual minorities and gender minorities. You can combine them together. A lot of times you'll see it as like SGM or sexual and gender minorities. But when we talk about sexual minorities, they can generally be defined as individuals that identify I'm on the left side here, these different identities. So the LGBTQ, I tried to bold those. We've got lesbian, a woman-identified individual who is attracted to women, gay and man-identified individual attracted to men, bisexual, an individual attracted to men and women, pansexual, an individual attracted to any gender. People sometimes get confused between bisexual and pansexual. Bisexual tends to be a little more binary focused, whereas pansexual tends to be more kind of across the gender spectrum. Queer is an individual who identifies on the sexual minority spectrum that may not ascribe to one of the previously mentioned labels. So this is an individual who is romantically, physically, or sexually attracted to individuals of their same gender identity or to multiple gender identities. So queer tends to be kind of an encompassing label. A lot of gender diverse folks tend to use queer a lot because maybe the traditional labels of, say, like heterosexual or lesbian or gay, like don't tend to fit super well for folks that are gender diverse. So a lot of times folks who are queer tend to I tend to use that queer term for that. And then I have the plus. So obviously there are bigger acronyms and there are much more identities than fall into this. You may hear things like demisexual, asexual, things like that. So that plus kind of encompasses all of those other things. So now moving into the right, we have gender minorities. So essentially these are folks who do not necessarily identify strictly with the gender binary. So when I say gender binary, it means like man, woman, right? So these can be defined as individuals who identify as transgender. What transgender means is an individual who does not identify with their sex assigned at birth. Non-binary is someone who presents their gender identity in a way that is um, not consistent with gender norms, an individual who either does not identify with their sex assigned at birth or has a gender identity that falls outside the gender binary. So this one is, kind of a large breadth. Some people do indicate direction, so they might be identified as like non-binary masc, non-binary femme. So you will see some variance in this as well. Gender non-conforming, essentially someone that just does not ascribe to gender norms. That maybe you might see someone that dresses a little bit outside of what would be traditionally considered clothing that would ascribe to their sex assigned at birth. And there are other identities as well that fall into this. Two-spirit, which is an indigenous gender diverse identity. You may hear gender queer, and there are others, but these are the kind of big ones that you'll hear frequently. So I just wanted to lay that groundwork for that, just because I don't want to assume that anybody is familiar with what these terms are. And so I just want to make sure that's clear before we move forward. All right, a little bit of prevalence and stats. One thing I do want to note before I go through these, there are many studies that compare mental health outcomes of LGBTQ plus people with their cisgender heterosexual counterparts. And sometimes comparing the stigmatized minority to the dominant majority can create this perception that the minority group is sick or damaged in some way. They're maybe deficient or there's something wrong with them. So I want to make sure that we're understanding these statistics within the context that they don't experience and walk through life in the same way, right? They have two very different lived experiences. And a lot of times what these statistics are stemming from are experiences of stigma, societal oppression, and group experiences, right? So before I go through these, I did, kind of want to lay that groundwork here before we, kind of interpret those. Um, so sexual minority individuals have been shown to experience higher rates of anxiety, depression, and substance use when compared to heterosexual individuals, and are more likely to seek treatment for these disorders than those who identify as heterosexual. So they do I have more, but they do also tend to seek treatment for them more, which may also contribute to that statistic. Sexual minority individuals who have experienced lifetime of daily discrimination were 2 times more likely to report the presence of a psychiatric disorder than those who identify as heterosexual. And sexual minorities have been shown to be 2 to 3 times more likely to have a co-occurring psychological distress and substance use disorders than heterosexual individuals. And they display elevated rates of 12-month and lifetime alcohol use disorder, as well as major depressive disorder, persistent depressive disorder, panic disorder, agoraphobia, social phobia, generalized anxiety disorder, PTSD, borderline personality disorder, and schizotypal personality disorder as compared to their heterosexual counterparts. Now, all of these, again, should be noted that they are linked to experiences of discrimination. And we'll move now to gender minorities. So one thing that you'll note is they do tend to be researched separately because the lived experiences are very different. So you'll note that a lot of times they are in 2 different studies. And sexual minorities in general tend to be researched a lot more than gender minorities do. So while we don't know a ton about sexual minorities, it is important to note that we know even less about gender minorities, unfortunately, because it is an extremely under-researched population. So from this one, I've got, so there was an integrated literature review on gender minority mental health. There are no specific studies necessarily on co-occurring disorders in either population. Most of them are especially in the transgender and gender diverse community, more just generally mental health related. So in this review, they looked at the number of studies that existed on these various different things. So I'm reporting them here for you. So in samples of studies these aren't necessarily studies that are on transgender or non-binary individuals. This is just that had samples that were included in the study. So that's important to note as well. But there were roughly 50 studies that reported depressive symptoms symptoms, 26 studies reported suicidality, 20 of them reported anxiety, 15 PTSD, and 26 reported general psychological distress. And our transgender adolescents show greater risk for substance use outcomes than cisgender adolescents. Kind of bleak. But okay, so one thing I do want to talk about. So there are two theoretical frameworks that I think are really important for understanding mental health within the LGBTQ community. And as such, I think kind of illustrates how co-occurring disorders might be caused by these two things. So the first one that I want to highlight is intersectionality. So intersectionality was a framework introduced by Kimberly Crenshaw. And basically the idea behind this is that our identities intersect in different ways that create unique lived experiences rather than just focusing on one of those identities. So for example, the lived experience of a Black gay man is very different than a white gay man, right? And then that can intersect even in different ways when we look at, social class or even just gender identity, right? So, a cisgender gay man is going to have a very different experience than a transgender gay man, right? And then all of those different things kind of layer and intersect in different ways. And so when we only focus on one aspect, this can lead to an incomplete or stereotypical view of that person or that population. And it also negates the idea that oppression intersects and kind of stacks on one another, right? There is the idea of multiple minority stress as well. And that was really the whole idea of, Kimberly Crenshaw's work was that you know, all of these things intersect in different ways and kind of create harder experiences depending on the different levels of intersecting identities that you have. Okay. The next framework that I want to talk about is the minority stress theory, which may be a theory that you are familiar with or not. It is very commonly used in the literature of looking at the LGBTQ community. So this was a theory that was introduced by Meyer in 2003. I bolded them down here, but it may be a little hard to tell. But basically, Meyer created this framework that basically explained how experiences of various types of prejudice and discrimination have impacts on the mental health of those in the LGBTQ community. And so those variables that they looked at are down here, which are expectations of rejection, identity concealment, and internalized depression. So basically, the whole idea behind this is that the psychological issues that minority individuals in society experience are a result of the stigma, discrimination, and prejudice that they face as a minority person. And as such, those negative experiences that they have trigger expectations of rejection, identity concealment, and internalized depression. So when we think of internalized depression, that means things like internalized homophobia, internalized transphobia, those things like that. And then these generally eventually lead to adverse mental health outcomes, and I would also probably suggest physical health outcomes as well. And so minority stress theory has been used to illustrate how co-occurring disorders might be caused by minority stress in general. And those things can lead to maladaptive coping, more alcohol use, psychopathology, psychological disorders, things like that. More specifically, there was a study done by it was Livingston and colleagues in 2017 that reported that experiences of discrimination and mistreatment were associated with greater odds of substance and nicotine use in both sexual and gender minority individuals. So I think these are two frameworks that I think to keep in mind as we continue to go through the rest of the slides. All right, so ethical and legal and ethical considerations. So I have up here the different ethical principles. I have the counseling ones here because that is my discipline. But I would imagine, depending on whatever your discipline is, that you probably have very similar ones. We have autonomy, non-maleficence, beneficence, justice, fidelity, and veracity, right? So the big thing with this, before I go too far, is there is a lack of specific training and research for working with SGM folks with dual diagnoses, okay? So these recommendations that I have in the following sections basically integrates what is currently known about working with clients who have substance use and mental health disorders with what is known about working with LGBTQ populations as a whole. Okay. So you're probably sensing a theme here that unfortunately this is an area that is very under researched. So if anybody is interested in researching this, I highly recommend it because we don't know a ton about it. Um, but when we go back up here to our ethical principles, those should be at the forefront of what we're doing, right? And this can be really difficult. If anyone you have worked with folks with substance use disorders or things like that, that can be difficult when working with folks with substance use disorders, right? I think it can be hard to um, I guess I don't want to say identify with what they're doing, but a lot of times it can be hard for folks to not make moral judgments or value judgments. And that's really important for substance use treatment as a whole, but also adding the LGBTQ community on top of it, especially when we think about the shame that folks might experience around their identity. So that can be really impactful, right? So those things can kind of intersect in really difficult ways. Those in the LGBTQ community experience morality and value judgments all the time, right? That's sort of the whole idea around the fear of, kind of disclosing your identity because you're afraid that someone might view you negatively because of that, right? Especially given the kind of current context that's going on right now. Folks can feel really unwelcome and not safe. And so that kind of goes down into that next bullet here. I guess I could use a laser pointer that might be easier for you guys to see. Um, into the creating safe environments, right? They can be really important for folks that feel that this is a safe space. And there are different ways that you can do that. Making sure that all of your materials are not, just geared towards the gender binary. Having different options for selection. Having a rainbow flag goes a long way, right, in your office. Just giving kind of clues that this is a safe space for folks can be really impactful when you're working with them. Being aware how oppressive systems within the social environment intersects to negatively impact the well-being of SGM individuals. So this is huge, right? A lot of times when folks seek whether it be counseling or psychotherapy or medical treatment or whatever, this is really essential to having an individual feel safe because if they are coming into you and you are generally oblivious to their lived experience, it's not going to be super helpful to the counseling relationship, and treatment retention might be low, right? Whether they come back to you or not is going to be huge. And again, with substance use, that's going to be really important. Um, Another thing to note in terms of ethical stuff is awareness of gatekeeping. So especially for our gender diverse folks that we work with, there is just gatekeeping like crazy in regard to working with them, right? When we think about things like, having to write letters for gender affirming care and things like that, we are the gatekeepers of that, right? So if you are a clinician and someone is, maybe their gender identity is tied up with feelings of depression and things like that, and as a result, substance use, we are the gatekeepers of whether or not they can get those services, right? And I think those are things that we really need to be aware of, kind of ethically speaking. When you think about things like gatekeeping, you don't require a letter from your therapist to get a breast reduction surgery, right? Or to get some sort of plastic surgery. But we require folks to have a letter from a therapist to get gender affirming care, even though they are very similar procedures. So I think it's important to note the barriers that are in place for folks to get care that would help their mental health, which may additionally impact their substance use and co-occurring disorders. Okay. Also, be aware of the facility that you work in and how that may impact SGM clients, right? So maybe you yourself are very affirming, right? But you work in a medical office, or something like that that is not. I think this is especially true when we have folks that work within religious hospital systems and things like that. Folks can sometimes be really nervous to go through those systems because the culture within that system may not be feel like a safe place for them. So I think it's important to be aware of the organization that you work for, what that looks like, and how that might impact your clients negatively. Um, Clinician self-awareness. This one is huge. It is really important that you yourself engage in an ongoing process to educate yourself and address your own personal biases. It is not enough to just, um, oh, well, I can just see them. I'll just put my beliefs about it aside. It does come through, like you have to be an affirming individual to work with these folks and be ethical. Um, you can't work with somebody if it's like, oh, well, I don't accept your lifestyle. Um, it bleeds into the work. And so please just make sure you're educating yourself, one, about what's going on. One thing I do want to note is something called emotional labor. And I don't know if that is a term that some of you guys have maybe have heard about, some of you have not, but I will mention it. Emotional labor is basically the emotional toll that educating somebody about the day-to-day experiences that you go through has an impact on. So, and a good example of that would be a person of color having to educate a white person about racism, right? Or something like that. Or again, a queer person having to educate a straight person on homophobia and discrimination that is very prevalent. You could do that research yourself. That is very easily Googleable. It is not on that minority individual to educate yourself for you. So you need to engage in that process yourself and not necessarily, put that on your client to educate you on things that are very easily Googleable. Um, Self-awareness is critical to minimal heterosexist and cisnormative beliefs. We all have heteronormative and cisnormative beliefs, right? Like, let's just accept it, right? We watch, what we see on TV is very, it's primarily straight cisgender folks, right? Um, I did some statistics. I don't remember. I'd have to look back, but I want to say like less than 2% of all things on television are uh LGBTQ, right? Like everything else is very like straight and cisgender. So um we're what's the word? Socialized to kind of have those beliefs. So it's just really important to see where those beliefs kind of come in and not just assume that everybody is straight or that everybody is cisgender. It's sort of the whole reason for the coming out process is because everybody just assumes that you're straight unless you come out. So, it's just really important to constantly be combating those and doing some work to look at those. Um, so there is a study by Salpietro et al. Who looked at different challenges that were posed by folks that were navigating healthcare systems and working with trans individuals. And these were some things that they experienced. So witnessing gender minority clients be misgendered by staff, transgender clients being ostracized from families for not dressing within the bounds of gender appropriate clothing choices, cisgender bias influencing the therapeutic alliance, and microaggressions by clinicians towards SGM clients. You would be shocked by the number of microaggressions that are um, put forth from clinicians or healthcare professionals onto SGM folks. So again, that is a whole nother topic that I won't have the time to be able to go through. But I do think that it is important to be aware of all kind of going back to your self-awareness and your biases to make it so that you can have the best therapeutic alliance as possible. Again, whether you're a psychiatrist or a psychologist or a counselor or a social worker, to have the best therapeutic alliance, because obviously that is built on trust and unconditional positive regard. And if your client does not experience that, your therapeutic outcomes are not as good, right? We know that the therapeutic relationship is the most significant predictor of outcomes over modality. And so just making sure that you're focusing on that therapeutic relationship is the most important. Assessment considerations. So, any of my psychologists in the room or anybody that does any sort of psychometric testing, know that most assessment tools have been developed using heteronormative and cisnormative frameworks, and additionally, most are not normed for those in minority communities. The LGBTQ community as well falls into that, but also people of color fall into that as well. Most of our assessments were normed off of either white college students or primarily men, and definitely not so much from our minority groups or the LGBTQ community. And so it is important to see how those biases, kind of come into testing instruments and their items, and just their psychometric properties even been evaluated for use in that population. There are some that are being created specifically for use within sexual minority or gender minority folks, but just know that most of the tools that we use have not been normed for them. And they also have been, they are built on heteronormative and cisnormative frameworks. Um, it is important to consider the numerous ways that heteronormative and cisnormative beliefs influence addiction screening, assessment, and diagnostic criteria while working with SGM individuals. The other thing to note, is just related to the history of diagnosis and things like that, and the framework that comes in with that, right? Homosexuality was a diagnosable mental condition, right, in the DSM. So we have to be mindful that, while we are making progress, those things may still impact addiction screening, how we assess and diagnostic criteria, and all that sort of stuff, right? So I think you can't erase the history of what these things look like and also how that contributes to the distrust potentially in the medical community or the diagnosis and just mental health community in general. Why folks are a little bit cautious, right? Lastly, consider and be mindful of the historical and modern inclination to over pathologize minority individuals during assessments. Again, I think this relates to all the previous things I've already mentioned, right? Between how these assessments are made, how they're normed, and then also just the history of, what we've considered pathological, right? We tend to pathologize anything that does not fit the norm or normal. And so I think, that's just generally how we have worked as a society. So you can't kind of just erase that impact from those things. So importance of advocacy. So being an advocate is really, really important. Again, I have a definition of advocacy from the American Counseling Association, which again is my professional organization. However, again, I would imagine you all have very similar depending on what your discipline is. And so ACA defines advocacy as the promotion of the well-being of individuals, groups, and counseling profession within systems and organizations. Advocacy seeks to remove barriers and obstacles that inhibit access, growth, and development. So it comes to no surprise, we already know this, that there are numerous anti-LGBTQ laws in force and continue to grow, such as those that criminalize healthcare for gender minority youth, create barriers for receiving affirming identification documents, prevent participation in various activities or sports activities, or relegate SGM individuals to use non-affirming facilities. Living in areas living in areas that have these discriminatory policies in place have been shown to increase vulnerability for psychological and substance-related disorders. So I think it's important to note and again, I would assume most of us are in Michigan, but Michigan is not perfect, right, in terms of various laws that are in place and different protections. It is better than a lot of places in the country. When I lived in Arkansas, there was no protection for me in terms of housing. And so I could have very easily gotten kicked out of my rental if the person that owned the property had so chose to, and there would have been no protections for me to do so. And I actually told somebody this while I was there, and they're like, they can't do that. That's discrimination. It's like, yeah, very good. But it's important to note that that varies state by state, and it's certainly not equal access. And so folks that do tend to live in areas that do have more levels of structural oppression generally have worse mental health outcomes and more vulnerability to mental and physical health outcomes. Dubois et al. Found that trans folks experienced better health outcomes in alcohol consumption and mental wellness when residing in areas of trans-inclusive policies and statewide protection. So that's sort of the flip side of it, right? Folks who live in areas that have a lot of structural oppression tend to have worse outcomes, and folks that live in areas that have protections for them tend to have better outcomes. Fairly self-explanatory. There's nothing shocking on that, but it does speak to the importance of advocacy for your work with your clients that, it's not just focusing on the individual, it's focusing on the systems in which they're existing in, right? Because you can only do so much at the individual level if the location that they're living in is actively causing harm to them. So I think, yes, you can do some at the individual level, but it's also looking at the macro. Okay, so let's talk about some treatment considerations. First and foremost, and I know I've already highlighted this, is the implications of minority stress. Discrimination is linked to mental health symptomatology, right? Including heightened anxiety, worsened and a depressed mood, suicidal ideation. So there was a framework proposed by a researcher named Hotzenbuehler, and basically he explained that stigma from others results in minority stress. It kind of like built on the minority stress model, which subsequently affects emotional regulation, social interactions, and thinking patterns, right? And so this all kind of branches out to impact different levels of psychological functioning, right? Um, and research has also shown that treatment options that are informed by, at least in part, by minority stress, may be more impactful and helpful for those in the LGBTQ community, and greater resilience and awareness of the impacts of structural stigma can help reduce psychological distress for LGBTQ individuals, right? So that's kind of first and foremost. I feel like a broken record here because I keep saying it, but it is really important. The next thing I want to note here is substance use as a coping strategy for traumatic experience. So anybody that has worked with folks with substance use, I think you would note that, or probably would notice that a lot of folks have had traumatic experiences, or at the very least, aversive experiences. Earlier on that they are kind of coping from using substance use, right? So I think this can be a really important framework to keep in mind, right? When we're kind of perceiving substance use in the LGBTQ community, especially when we think about, again, what the lived experiences look like, what it's like to live day to day, having to worry about like what rights are getting taken away, things like that. Which I'm going to go down to the next point, but it does kind of go back up to the previous point a little bit, which is this suicidality. So those in the LGBTQ community are at higher risk for suicidality, and those with co-occurring disorders are at a particularly increased risk. Higher occurrence of lifetime suicide attempts in the LGBTQ populations are higher than those in the cishet individuals or cisgender heterosexual individuals. There are a lot of stressors that are unique to LGBTQ individuals, such as uncertainty around whether they should disclose their identity because of experiences of discrimination or worried about discrimination. Those generally explain the overall increased risk of suicide. There was a study in 2014 that was done that found that substance use actually mediated the effects of gender and sexual minority stress on suicidal ideation. Indicating that folks in the study use substances in part to cope with the challenges of minority stress. So I think that's an important perspective to keep in mind, that the substance use actually helped reduce their suicidal ideation, right? So just as a way to, I think, kind of empathize with the experiences of clients and understanding patterns of behavior, right? Social support is hugely important. LGBTQ plus individuals often struggle with a sense of belonging with their community due to homophobia, transphobia, discrimination, and oppression. Low social support is connected with worse mental health and substance use outcomes for LGBTQ individuals with co-occurring disorders. Rejection from family is pretty big too. It's a large risk factor for worsened mental health and substance use. And the flip side of that is family acceptance is associated with higher self-esteem, better overall physical health, as well as lower rates of depression, substance use, and suicidality. Treatment barriers. So there are a lot of barriers to treatment. In a study of 2,778 folks, it was found that 62% of participants reported that they could not pay for mental health services, and 52% reported having no or inadequate insurance. In addition to financial barriers, 46% reported feeling uncomfortable discussing their mental health concerns, and 43% felt a sense of shame about their mental health struggles. And past biased reactions from mental health professionals related to LGBTQ plus status also discouraged folks from seeking needed services. Gender minority folks tend to face even more barriers, and they're even more vulnerable to discrimination when compared to their sexual minority counterparts. Um, I would say in general, like just um, finding facilities too is hard. That, you know, when we think about like for folks that need to be hospitalized or whatever for substance use treatments, generally speaking, they tend to be more efficacious for LGBTQ folks that when they can get affirming treatment there. So when a lot of times a lot of treatment facilities don't necessarily have specific programs for LGBTQ folks, or it's not really a part of you know, maybe their uh what's the word, advertising materials or things like that. So there's barriers, and then you also can't ignore the impact of other systemic things that fall into this as well. You know, in terms of like employment and things like that related to the LGBTQ community, because there's also discrimination in the workplace, which could experience issues getting health insurance, which then you know, creates things down the line, right? So all of these things are interwoven, and that's why minority stress theory is so important when we think about working with folks. Affirmative treatments, I'm going to go into a little bit more in the next slide. But generally speaking, these affirmative treatments are structured to provide support and acceptance for all SGM identities. And they're likely to include paradigms related to significant impacts to minority stress, which is what I've talked about. I did put the 4 different principles related to affirming treatments in here if you are not familiar with it. So the first is encouraging insight into the relationship between minority stress and mental and physical health, reducing feelings of shame and guilt related to LGBTQ plus identity or identities. It's important to note some folks do have more than one LGBTQ identity. Challenging maladaptive thinking patterns that lead to reduced self-esteem, and increasing resilience and connection with the community. Okay, so these are the 4 guiding principles of affirming treatments. Okay, I did want to highlight unmet treatment needs and future directions in case there are folks, again, that this is something that kind of fits into your research area or your work as a clinician. I've already talked a little bit about treatment access, but folks in the LGBTQ community are unlikely to find specific programs that fit their needs. Statistics on that are roughly only 12% of mental health facilities and 17% of substance use facilities offer LGBTQ specific programs. Racial and ethnic minorities within the LGBTQ community, even less so. There is in general a lack of research on unique treatment considerations for gender minority individuals. I know I mentioned this way in the beginning, but we know more about sexual minorities than we do gender minorities. Gender minorities generally kind of get the shaft when it comes to research. Both do, but gender minorities even more so. Much of the current research on LGBTQ individuals looks at them in kind of generalized monolithic terms rather than viewing as a heterogeneous population. So what I mean by that is a lot of studies just lump them all together into one experience, when each one of those, if we were to go back to this slide here, look at all these different lived experiences, right? And all these different identities. And so everybody's going to walk through the world a little bit differently depending on how they identify, and just how that intersects with the world, right? And so go back here. Um, so I think it's just really important to just not lump everybody's experiences together. And then when you take intersectionality in mind with that too, about like, again, thinking about different identities, people of color, all that sort of stuff that might fit into that. It's just really important to not always just look at it as like this homogeneous population. It is a heterogeneous population, and know that there are different lived experiences within that. And despite the evidence that LGBTQ individuals need culturally competent affirmative services, they are often not readily accessible by those who need them. And especially when we think about our folks that are in more rural communities, rural areas tend to not have any LGBTQ programs. All of those tend to be in bigger cities. So again, when we think about access, those in the rural communities are going to have a harder time finding services as well. So the experience in sometimes these facilities in rural communities tends to be really damaging. So I had a client who was a non-binary client, and they were in a mental health facility, and they were diagnosed with a personality disorder because they got angry with the staff for not using their correct name and pronouns. So they were continually being dead named and being only using the pronouns that were assigned to them at birth and not their accurate pronouns, but they received a personality diagnosis there because they got angry with a staff member. So I think it's important to note that those experiences happen, and it kind of goes back to the pathologizing that that community goes through. On almost some level of like professional gaslighting, right? So, just to note that not all experiences are going to be good ones. And so if you do have clients that are, in need of hospitalization, for substance use stuff, to make sure that do the best that you can to try to make sure that the facility is, not going to be damaging to them or cause more issues, um, than they went in for. So. All right, y'all. I know I just gave you a whole lot of information in regard to stuff. I threw a lot at you. I just some things to keep in mind, as you're working with folks, just in general. So have my email here. If anybody wants to reach out to me, feel free. Most of the information from this came from a book chapter that I published with some colleagues. I have linked the book below. It is actually a book entirely on the treatment of folks with co-occurring disorders from a counseling and psychotherapy perspective, and they have various different populations, but this chapter was one in it. So I have linked it in case anybody is interested or, wants to read more about different populations. But again, I appreciate you guys listening, and I'm happy to go through the questions, Megan, whenever you are ready.
Thank you so much. That was a really fantastic talk. Let's see. So it looks like there is. Okay, so one question is have you read Decolonizing Therapy, and does this framework inform your work?
I have not, although it sounds fascinating and I would love to. But I think just the framework of decolonizing kind of comes in as well, right? I think all you can't like those systems are all intersecting, right? Like there's just no way to, kind of unpack. And a lot of the stuff that, especially when we think about gender minorities, we have found that as more colonization happens, it more society moves towards the binaries, at least in regard to gender. So I think you can't separate any of those systems. So I've not personally read it, but I will add it to my list.
If while we're waiting for potentially other questions coming in, I do have a question.
Yeah.
So I'm a research faculty and focus on substance use in adolescents and young adults. And like, what would you say are the greatest research gaps in our understanding of factors contributing to both risk and resilience, specifically in substance use among LGBTQ plus youth?
I hate to say anything,
Yeah.
but in general, I mean, so my research focuses primarily on resilience and thriving kind of generally. I would say we know more about resilience than we do thriving. And resilience, I would say in adolescents, even less than adults. So I would say in general, I have found that adults tend to be researched a lot more than adolescents. And so I would say with factors related to adolescence, it's going to be a lot of, um, things related to family acceptance, access to, gender affirming services, things like that are going to be huge. But I would say, unfortunately, the gaps, again, like when I say like there really isn't much on gender minorities, period, even less so on adolescents. I think with it being kind of a protected population, researching kiddos is hard anyway. So, so I would say
Yeah.
just anything that you're interested in looking at, I think would be a benefit to the literature.
Yeah, and I think it's such a difficult landscape right now, but
Mhm.
for studies that aren't focused on this population, at least, asking how they identify in a broad way, and then potentially being able to look at those differences and, all studies, like all studies should have these, questions.
Yep. Yeah, and you're right. It is especially difficult now given the restrictions, on, with the federal funding limitations and some of the things that they don't want things asked about. So it does make
Right.
it a little bit more difficult to look at these things for sure.
Okay. Another question is for the rural folks with less access to inclusive care, how have you found telehealth to be as a resource for them?
Yeah. So I would say telehealth is huge. Now, sometimes there are issues related to internet access and things like that, kind of depending on what that looks like. But telehealth is definitely big. But again, when we think about, substance use and things like that, that can be a little bit difficult as well, depending on, you have to worry about things when it comes to telehealth, like where are they? Safety concerns related to that. But telehealth is really impactful if there is good enough, internet, for them to be able to do that. So, in terms of my work, I would say most of my folks, were kind of around the location of where my office was. I did have quite a few telehealth folks, but I would say really the big concern there is reliable internet access.
Okay. Um, and another question, have you worked with autistic LGBTQ plus people, and how are their intersectional needs researched, if at all?
Not at all. Sorry not to laugh because that's a wonderful question, but not
Mhm.
at all. Um, I would say there is, a good percentage of folks who are neurodivergent and LGBTQ, they do tend to intersect. Um, and so I think there's, this willingness to kind of think outside the traditional box than what we typically look at. I would say I will say I haven't personally worked with a ton who are on the spectrum and LGBTQ. Again, it's we go even more specific with substance use. Um, but I would say in terms of specific needs, I think finding folks that I think it kind of goes hand in hand, right, with like finding affirming folks. Because finding folks who are affirming of autism spectrum stuff is also difficult, right? That aren't, some ABA therapy is great, but there are some that is very, almost like kind of conversion therapy, but folks who are autistic. And so I think finding someone who is, aware and willing to kind of be flexible and things like that is going to be hard. So it's almost like you're having to find affirming therapy on two fronts, if that makes sense. It's like affirming and aware of like the specific needs of neurodivergency folks and so, autism specifically, and also LGBTQ, so you kind of have like an intersection there that makes it additionally difficult.
Um, and how can clinicians ensure their screening and assessment tools are inclusive and culturally competent for LGBTQ plus individuals?
Ooh, that's a big question. So, first is you're going to have to look at the psychometric properties of your assessment, right? You're going to have to look at who made it, who was normed by it, and if you're using any sort of big psychological assessment tool, you have access to that, and really you should be looking at that when before you use anything. Look at who it was normed for. Check for cis-normative language, right? So, are all the languages he, she, right? Are there various assumptions related to identity in that is normal, what's considered normal, very like gender normed, right? And so I think you're going to have to just look at each because, there are a million different assessments. So I couldn't speak to each of them, but you're going to have to do the work to look at the psychometric properties of the assessments that you're using, look and see what they were normed on. And, if it's, a fairly well-known assessment and it wasn't normed for use, I think you just need to keep that in mind as you're interpreting those results, right? Of like, how is that bias potentially coming in here? Is there a piece of this that we need to take with a grain of salt? So I think it comes in one, you looking at the tool that you're about to use and also how you're interpreting it, if that makes sense.
So there's a professional development question. Do you have any recommendations or pieces of advice, insight for anyone early in their career path For example, working as a research assistant or other entry-level roles, wanting to do further LGBTQ plus research as a career. Speaking as someone who is interested in graduate school in the potential future and figuring out doing either a PhD or research outside of academia.
Yeah, absolutely. So I think that would depend on what discipline you're wanting to go in. So for example, so in the psychological community, there are different divisions that focus on different things. So the LGBTQ specific division in APA is Division 44. And so Division 44 is going to be a great resource for kind of psychologically minded LGBTQ research. So if that's something you're interested in, that's a way to go. For the Counseling Association, we have our own kind of organization within that called SAGE, SAIGE. That's within, the American Counseling Association. So it really just depends on where you're wanting to go, right? Are you wanting to look in public health and policy? Are you looking into psychology? Like, depending on what route you want to go, there will be interest areas and also probably divisions, hopefully, in whatever division that you're wanting to look at. But I would say, at least in my experience, the ones that I have utilized the most are Division 44 of the American Psychological Association and SAGE in the American Counseling Association.
Okay. Okay, this question, reflecting on the discussion regarding barriers to care in gender-affirming surgeries, particularly regarding the requirement for a psych letter compared to other types of plastic surgery that don't have the same stipulation. I'd be interested in hearing your thoughts on how we can approach this issue, especially after experiencing a situation where a patient who had undergone gender-affirming surgery later expressed a desire to reverse it, even labeling the original procedure as immoral. How do you think we can provide care without acting as gatekeepers, and what safeguards or alternatives would you suggest to better support patients in their decision-making process?
Sure. So one thing I want to note that I think is really important to note is gender affirming care does not equal surgery, right? So there are many, many forms of gender affirming care that do not involve surgery. So I think we need to be really careful to make sure that we are not always equating gender affirming care to surgery, because that tends to be what ends up happening, and that's not true of what all of that always is, right? So that's point number one, right? There's hormone replacement therapy, which women who are going through menopause also go through, right? Or may go through as a treatment option, right? And so a lot of these treatments are used in other circumstances that aren't just used in regard to gender affirming care. So I think also things like puberty blockers, for example, for children, those are used in children that have other medical conditions as well. It's not like they are only used for that. So I think that's really important to kind of think about. Also, the statistics related to reversal, less than 1% of all folks who experience gender affirming, if they do go with surgery, want it to be reversed. So I think to be careful to not have one experience basically be applied to everybody. When it is more people, I think I saw a statistic that said more people regret watching the Harry Potter films than regret having gender affirming care or their surgery. So I think don't let that be skewed, right? Now, in terms of like specifics, I think it's just noting that that exists, right? And being mindful of, and now that's going to depend on whatever you feel in terms of comfort level, right? In terms of writing these, writing a letter or things like that. It's important to note that you have to write a letter even to do hormone replacement therapy, right? It is not just for surgeries. It is any single type of gender affirming service. So I don't know, safeguards. I mean, that's going to be your professional judgment, right? And you could do your own due diligence. And also, we have to think about from an ethical perspective, if we're not doing it, I'm sure what we don't quote are the people that have plastic surgery and regret having plastic surgery, or people who have multiple plastic surgeries to fix the plastic surgery that they had before because it didn't come out the way they wanted, right? So we're looking at things that are very similar, but we're putting a value judgment on it. Because it's gender affirming care versus not, right? So I think there's a lot of different moving pieces to that. And so, there are folks that, as a practice that, you don't have to be an active client, that you can, do a session or two with somebody and then they will write a letter for you, or they won't, depending on whatever that is. But I think it's to note that we think about things like autonomy, right? That it is important for clients to be able to make decisions for themselves. Okay, if they get plastic surgery and they regret it, that's their choice. They made that decision to do that and they can have the surgery to fix it. Same with gender affirming therapy. Why do we have to be the gatekeepers of that? Why can't someone make that decision on their own, right? So I think just to think about the parallels of things that occur naturally already in the medical space that we don't require gatekeeping for that we do. So I don't know if that makes sense or if that answers your question, but there are a lot of moving pieces to that. I think we can get very skewed in how we view it.
Yeah, those are some really good points. Um, Another question I have is, are there certain subgroups that are more vulnerable to certain types of substance abuse, or I guess type of substance that's more common and like how you kind of navigate that? Because there is so much heterogeneity within LGBTQ plus individuals. I know back in the day when I did do some clinical work, I worked at center at Halstead in Chicago, which serves this community. And at that time in the mid 2000, like crystal meth was like a big problem in the gay community. So I don't know if this is something, that you see that like, I don't know if like opioids are more prevalent, opioid misuse in certain populations or not.
Yeah, that's a great question. I don't have specific data to that. I will say most of the research that I have seen has been primarily alcohol use. Alcohol and nicotine tend to be the two that I see the most of, in the literature at least. Um, but in terms of like specifics within like specific communities, um, I'm not super familiar with that data. But I would say alcohol tends to be what comes up the most in the literature.
Hmm. Okay. Okay. Final question. We'll do one more, possibly another, if anyone has a short question they want to ask. Um, how can we protect the mental health of LGBTQ plus clients who are being potentially re-traumatized by ongoing public debates about their identities and rights?
That's a great question. So, I mean, it is one of those things that unfortunately, this is not new. The debate on queer and trans human rights is not new. It's been going on, forever. Um, just be an ear to listen to, just be, someone to empathize, be an advocate, um, because you are only one person and they are only one person, but to try to, focus on strengths, focus on positive identity development, um, safety plans are going to be huge, right? We think about substance use stuff, right? Harm reduction, um, you know, safety plans are going to be really big, positive coping as much as possible, self-care, and just being empathetic and validating and, you know, being an advocate yourself, are really the big things. I mean, I think we're while what we're experiencing right now is not new, it is uncharted waters a little bit with how quickly everything is kind of moving. And so, I think the big thing too is thinking about just the safety that people feel walking about in the world, right? And I think we talked about this a little bit earlier about, I think folks that have ideologies that are anti-LGBTQ are feeling a bit emboldened. We saw with the last administration, the last Trump administration, hate crimes increased significantly. And I suspect that we will see that again. So I think to really the big thing, and this is when you work with any minority client, doesn't matter whether they're LGBTQ or, they're black or brown, make sure that you're validating those experiences of fear, right? And being worried and, um, don't just brush them off, right? It can be really easy as someone who's a part of the dominant majority to just brush them off as being, oh, you're just being anxious, right? They're very real concerns and they're understandable. And so I think the big thing is being empathetic and validating and also thinking about how can we bolster strengths and positive coping and safety.
Okay, great. That's, I think, a good ending point. Thank you all so much for attending and also for the really great discussion that we had. Yeah, again, thank you, Deb. We really
course.
are thankful that you came and shared all this great information today.
Absolutely.
Great. Bye, everyone.